for joining us this week. As always, we're going to give it just a minute to allow the room to fill up before we go ahead and get started. Hello, hello. Thank you all for joining us this week. I'm going to just take some time before we go ahead and kick off the webinar. Okay. Give it just one more minute. Alrighty. Good afternoon, everyone. Thank you for joining us once again for our weekly Wednesday webinar series. Today's webinar is on equitable access to behavioral health treatment for the bleeding disorders community. My name is Alsan Murtha, and I am the moderator of this series. At any point during the webinar, if you would like to ask a question, please use the Q&A feature at the bottom of your screen. And if you're joining us from one of our social media streaming platforms, you can go ahead and enter your questions in the comments, excuse me. We have staff members monitoring these questions, which we will pose to our speakers after the presentation. This webinar is being recorded and will be available to the community beginning on Friday, March 3rd. I am joined today by an amazing team. We have Kate Bazinsky, Chair of the Bleeding Disorders Substance Use and Mental Health Access Coalition, Jacqueline Bacardi, a licensed clinical social worker at the Yale Hemophilia Treatment Center, NHF Senior Policy and Healthcare Analyst Marla Feinstein, and Lucy Ramirez, a social worker at the Rush University Medical Center, HTC. Thank you all for taking the time to join us today. I will go ahead and turn it over to you to get your presentation started.
Great. Thank you so much, Alsan. And thank you to NHF for hosting us today. This is really exciting. We're thrilled to be here. So today's goals really is to, we have 4 goals. First of all, to raise awareness among the bleeding disorder community about the barriers to residential and inpatient behavioral health treatment facilities for people living with bleeding disorders. To share resources to facilitate access to treatment, and to educate the community on what to do in the event of a denial, and to share more about our coalition and to share some opportunities to get involved, because we would love to have your involvement. Alsan did a fantastic job of introducing our crew, so I won't go into it any further, but I am Kate Bazinsky, so I am the chair. And I'll start with a little background of the Bleeding Disorder Substance Use and Mental Health Access Coalition. So this all began about a year ago when a young man named Derick, he had severe hemophilia and a history of substance use and mental health conditions, and he hit rock bottom. And so he went to his hemophilia treatment center nurse, who had worked with him for his whole life, and said, I need help. I am ready for treatment. And she called all of the residential substance use disorder facilities in the area, and no one would take a person with a bleeding disorder. And so without access to appropriate treatment, Derick unfortunately went home, he overdosed, and he died. And so when that happened, Jen Feldman, the nurse at the treatment center, came to the New England Hemophilia Association and said, how can we stop this from ever happening again? You know, and the New England Hemophilia Association reached out to NHF and HFA, and we began the Bleeding Disorder Substance Use and Mental Health Access Coalition. And we are a diverse stakeholder coalition with representatives from NHF, HFA, Hemophilia Treatment Center providers like Jackie and Lucy. We also have a number of local chapters involved, in particular North Carolina and the Hemophilia Council of California, as well as community members. And our mission is to advocate for access to appropriate substance use and mental health treatment facilities for all individuals with bleeding disorders. But really, the barriers to access have been in regards to the inpatient and residential treatment facilities. So that is where we are focusing our energy on ensuring access. And why does this work matter? Well, we believe that access to residential treatment is a health equity issue. We believe that every person, regardless of their presence, regardless of whether they have a bleeding disorder, whether they can clot, what medication they use, what state they live in, every person should have access to the mental health and substance use disorder treatment that they need. And so I will turn this over to Marla to share what we did first.
Okay, so thank you, Kate. So what we did first was a national survey, right? We wanted to determine if this was something unique with respect to Derick or Massachusetts or whatever. And we did a national.
Sorry.
I was like, wait, why is it changing? So we did a national survey of all providers. When I say all providers, I mean, it was sent to all HCCs providers, including social workers, nurses, physical therapists. And what we found was that we did get a significant response rate from the provider group, right? The HTC responses of those that responded, 42% responded, but of those included 59 HTCs, representing the 42% of the US. For reference, there's a total of roughly 141 federally recognized hemophilia treatment centers across the country. Of those that responded, we had a wide range, as I mentioned, of provider types, including nurses, social workers, hematologists, and physical therapists. And the nice thing about having all those different provider groups respond was that it gave us a really robust 360 view of the provider perspective from the HTCs. Next slide, please. And unfortunately, what we learned is that 83% of those who responded to the survey, who reported who attempted to refer a patient, reported denials, unfortunately, meaning that they were not able to place their patient in a residential treatment facilities. There was also 70% which had success, but that's not a significant amount, right? We're focusing more so on the 83% who received denials. Next slide, please. And what we found is that they came from all across the country. This was not a uniquely Massachusetts problem. That was not a unique HTC issue. It was not a pediatric issue. What we found was that 17 states of the reported denials, we didn't we have 3 non-survey denial reports, meaning since we did the survey about a year ago, we found that there's been significantly more numbers of people that are reporting denials. And we didn't get respondents from 21 states, and we only had 11 states where there were no reported denials. So what does that mean? It means that these states, irrespective of where they're located, whether it's urban or rural or region of the country, they're all reporting denials. Next slide, please. What we also found is that we wanted to know, is this just Derick, because he was 20 years old? Was it pediatric and adult? Okay. And what we found was that these denials impacted both pediatric and adult populations. And as you can see here on this slide, on the left-hand side, what you'll see are pediatric, and on the right is adult. And what we did is we categorized them based on whether or not they had a denial for a substance use disorder facility, a mental health facility, or both. And what we saw was that they were both in peds and adults, and also for both types of facilities, meaning both mental health and substance use disorder. Next slide, please. And as I mentioned earlier, this just breaks it down a little bit more in terms of who was exactly being denied, whether it was pediatric or adults. And what we saw is that it's irrespective of pediatric or adult type of place in the country, state of residence, whatever it is that this seems to be a large, much broader problem than we had known prior to this study. And now I'm going to toss it over to Lucy.
Thank you, Marla. So, it's important that we did do the survey and establish the scope of the problem, because we were able to answer three important questions. One is access to residential treatment a problem, and that was a definitive yes. And was this related to just one geographic area, or was it more of a larger scope? And there was definitely a national scope that was found out, which I think you can see from the map that we've shown. It was across the country, from the East Coast to the West Coast, just about in every region. And are there certain populations or facility types that are more susceptible to the denial issues? And again, clearly by looking about across the different populations that are served by HDCs, they were reporting that it was happening for both the adult and the pediatric populations, and it included both people seeking substance use treatment as well as mental health facilities. And I think this is an important point to make, is that it is such a large national scope, because coming from the provider side, working for many years on the inpatient side and trying to find facility placements for your patients and running into barriers, a lot of times you'll say, oh, well, it might just be the problem with our area, or the problem with this particular patient, or maybe the problem is with me. I just don't know what to do and to give up. But it was important to know that, no, this is happening everywhere. And if you want to hit the next point, Kate, on the slide, that it showed us that it can conclude that this is a problem that is national in scope, and it requires a national response, which means that we are fortunately part of a community that has a very strong advocacy in all areas of the country for our patient population, and that we could draw on these resources to act on this problem. Next slide, please. So, and once we had gathered this information from the HCC providers about the denials, we decided that it was important to interview the providers that had responded to the survey and to discuss what were the causes for the denials to care. And importantly, we considered not what were the things that were causing denials, but also the things that were helpful. But looking at the issues that were brought out in these interviews that were conducted after the survey, we found that there were 5 different areas that denial categories that the respondents gave us. The first area was infusions. Most of these facilities are not familiar with giving IV medication infusions, and that's just not for bleeding disorders. That's for a lot of different medical conditions that require medications that need to be given with a needle and directly accessed into a vein. They also said that their staff did not have the expertise to monitor hemophilia medications. They did not know what would be an unusual response to the medication or what was an expected response. And they just did not have the ability to manage the infusions in that particular facility. The other concern that was brought up was the presence of needles in the behavioral health residential facilities. Safety is often a concern for the staff. And so for the substance use facilities, what the concern was would this be a way for the patients to perhaps abuse drugs while they were in the center if they were looking for substance abuse treatment, and would it allow them to do IV drug use in the facility? And or would it be something that could potentially be harmful if they used it for other means? And concerns about, in a lot of acute psychiatric treatment facilities, they don't even allow the residents there to have regular cutlery like knives, forks, and spoons, just because of the risk of they could possibly be used as a weapon or for self-injury. So that was the other concern. Another issue that was brought up was the fear and medical complexity. A lot of patients with bleeding disorders are used to running into providers and other professionals who are just not familiar with bleeding disorders or rare medical conditions, and the fear that the condition would be too complex to manage and that they would not know what to do, for instance, if the patient started having a spontaneous bleed on the unit. And also, would the treatments, the going through the withdrawal, the detox part of the treatment, would that lead to would that cause the patient to bleed, and then what would they do? Or, you know, if the patient was on the psychiatric unit and had to have a hold, would that mean that they would not be able to protect the patient or the staff in the same way because they had to avoid touching them because they might cause a bleed? And then insurance is always a big issue whenever you're doing a transfer of care to an inpatient residential facility. Whenever they're looking at the potential cost of having the patient on the unit, they're often looking at what is the cost of the treatment plan, what is the medication cost going to be for the facility, and will this be covered by the regular source that the patient is able to use to access the factor, or will there be the issue of them being inpatient and not being able to get it? And will the insurance will there be just a regular copay just in general for the treatment that the patient or the facility would not be able to get around in order to make this admission happen? And then the other big issue is that many of these types of facilities, there are basically two types of facilities that provide mental health treatment and substance use treatment. Some are connected to an acute medical hospital, as our hospital has both an acute psychiatric treatment facility as well as one for patients that are detoxing and going through substance abuse treatment. But many medical centers don't have that, or many psychiatric units and substance use treatments don't have a connection to a major medical facility as well, or obviously one that has a hemophilia treatment program associated with it. So freestanding programs are not used to working with specialty medical pharmacies like are often involved in the care of our patients. So they did not have a way to access factors through the normal pharmacy channels that they're used to. Next slide. So after we found these 5 common areas that were often coming up for denials, we were able to develop 5 potential areas for policy intervention. And it was all meant to target how do we get around the treatment facility denials. And the areas that we looked at were, where are these policies coming from? And for the substance use treatment facilities, we had decided that that was something we were going to look at first, just because there was a national agency that was involved in developing their criteria for most substance use treatment facilities, and that's the American Society of Addiction Medicine, known as ASAM. So understanding what their policies were and how the facilities were interpreting these policies was important. The other area that we decided to look at was the fears around the medical complexities, the infusions. This was something that I think we felt in the community most confident that we could deal with, that we could provide the education that was necessary to help with that. So that was another area that we were looking at. And also this issue of discrimination and access for patients with bleeding disorders and other complex medical issues. How do we get around these often unspoken regulations that exist on these type of facilities? You know, figuring out why they exist and whether or not they coincide with the law in regards to providing equal access to patients. And also considering how do we deal with the insurance issues. Could there be in some way that we were able to address the issue for patients needing access for nursing home facilities? Could there be some way that this could also be used to deal with these freestanding institutions that were servicing our patients? And again, looking more getting into how do we actually work around the issue of access to medications and making some connections with the specialty pharmacies and talking with both sides to get some sort of agreements arranged so the patients could be able to continue to use their factor while they were in the hospital. Next slide, please. So based on these areas of policy, we were able to develop an advocacy roadmap. And as I had mentioned before, looking at ASSAM's criteria and communicate how to change that and dealing with these fears, we thought it was important to provide tools for HTC staff and other medical providers to understand what to do if they encounter barriers to getting their patients the type of care that they need in these facilities, and dealing with some of the resistance that we were getting, and making them understand what in fact is a stable patient with a bleeding disorder, because stability is an issue that came up over and over again for the substance use and mental health facilities. And looking at how do we deal with the current federal and state regulations that surround admissions for mental health and substance use treatments, and what can we do legally to address some of these regulations and perhaps make sure that they're either being looked at and reconsidered or enforced in the case that they're going to help our patients. And also continue along with trying to, as I mentioned, with the nursing homes, trying to use that and trying to continue to gather the data that was necessary in order to work with the SNFs and to change those policies. And as far as the access to the medications, that was something that we still continue to work on. We're still gathering information from other providers, from the pharmacies that we work with, to figure out what are the issues insurance-wise and what can we do to facilitate these connections with the behavioral health facilities that we're trying to get our patients in. Next slide. So Jackie is going to talk about the next section of our presentation.
Thank you, Lucy. Thanks, Kate. So the first step on our advocacy roadmap was clarifying and changing the National Substance Use Disorder Treatment Criteria. Next slide, Kate. Thanks. Nationally, substance use treatment programs utilize a criteria from the American Society of Addiction Medicine, or ASAM, for admission. The ASAM criteria provides levels of care for substance use treatment. After reviewing the language, we realized that patients with bleeding disorders could access outpatient or hospital-based treatment, although we're being denied from residential or inpatient treatment or ASAM level of 3 care, even though they were medically stable and appropriate for this level of treatment. So what we did was we spoke with the editor-in-chief of ASAM, who informed us that they were in the process of revising their 4th edition criteria, and they requested that the coalition provide them with specific language to be inclusive for patients with bleeding disorders for all levels of care. Next slide, please. After compiling the information for ASAM, we received MASEC endorsement of the work the coalition created. MASEC provided a letter of support, as you can see on the PowerPoint, from Dr. Amy Dunn, and we included that in our submission to ASAM just to have that scientific support, which we thought was really important. Next slide. So BD Sumac advocacy is working. This is really wonderful. We heard back from ASAM and learned that they incorporated the inclusive language we provided in the draft 4th edition criteria. Here are 2 quotes, and the second one truly encompasses what our coalition was advocating for, and I'm going to read it. If a condition can be self-managed by the patient, for example, a blood clotting disorder, or managed effectively by an external provider, it should not be used as a reason for exclusion from any level of care. Which is incredible. So we are hopeful that once the 4th edition is published in the fall, it's hopefully going to be published in October, we will have more success in referring patients with bleeding disorders to residential treatment. Next slide. So next on our advocacy roadmap, we took the information that we learned from our national survey, and as Lucy mentioned, we completed interviews with the providers who received both denials and successes. We thought understanding not just from the people who received denial, but also from the people who were successful. What did they do differently to get their patient into a substance use treatment program? A common theme, as Lucy had mentioned, was fear related to the medical complexity of bleeding disorders and needles. Next slide. So we created a toolkit for providers called the Best Practices for Accessing Residential Substance Use Disorder Treatment for Individuals with Bleeding Disorders. Next slide. Thank you. The toolkit offers a few considerations, including determining the appropriate level of care. For example, does this patient actually need residential placement, or can they attend an outpatient program to work on their recovery? Preparing the patient for the call with the residential substance use facility by encouraging the patient to discuss their substance use disorder as their primary diagnosis, and that they are ready for change and recovery. The provider call with the facility, which stresses that their patient has a stable medical condition and they are independent in managing their care, and also have the support of the HTC if as needed. And lastly, what to do in the event of a denial. Next slide. We created a letter that the HTC provider, or really any provider, can give to the facility regarding the stability of the patient. And we also created basically like a bleeding disorder 101 for facilities that they can refer to really understand, what a bleeding disorder is and how they can, work with somebody with a bleeding disorder in their facility. These two documents, we received MASAC endorsement for both and also for the toolkit. Just as a side note, I actually recently used the toolkit last week for one of my patients. My patient was denied getting into a behavioral health inpatient residential program. And I referred back to the toolkit that we created, and I went through the steps that we put into the toolkit, and eventually our patient was accepted into the facility. So we know that the toolkit works, as evidenced by me using it last week. So that's really exciting, that all of the work that the coalition has done in the past year is actually working. Next slide. So we wanted to take some time to really go over what I was talking about in the toolkit, what to do in the event of a facility denial. I know there's probably a lot of community members on the call, or individuals with bleeding disorders, family members. And we really wanted to, talk to you specifically about, if you are in this situation, what should you do? What can you do? And the first thing is, don't give up. Although denial statistics can be a little scary to see at that 83%, people with bleeding disorders can access behavioral health treatment, which was evidenced by my patient last week. It just might take longer time. And that's why you have this coalition to work with your provider on that. So the second point is, call your provider and suggest that they reach out to BD Sumac. As you can see, we have Marla's number, we have Mark's number, and we have Kate's number. Have your provider call somebody from the coalition. Ask the referring provider to have the facility give a reason or explanation for the denial. Sometimes if you're in this situation, you could be in the hospital or an emergency room, so the referring provider might not be your hemophilia treatment center or your hematologist. So make sure that you ask that individual who is making the referrals. Ask them to have the facility give an explanation, because maybe we can explain that as the hemophilia treatment center or your hematologist can give them more assurances around bleeding disorders. Also suggest that your provider offer the facility education and assurances, like I just said, about your stable medical condition. That's an extremely important word. Those are extremely important words to use. stable medical condition. As I discussed before, the reason you're accessing treatment isn't for your bleeding disorder, it's for the behavioral health condition that you're experiencing. And it's really important to stress that the bleeding disorder is a secondary diagnosis and it's stable. 5, request that your provider get a letter from the facility detailing the denial. This actually might be the most important point. We need it in writing. We need the facility to specifically say why they're denying you, and having a letter. That way, as Kate's going to talk about in a few minutes, what we can do on a state and federal level with that. And lastly, submit your denial to BD SUMAC. On our last page, we're going to give our information, our contact information, or you have Marla, Mark, and Kate's information there. Next slide. And Kate, I'm going to pass it over to you.
Great. Thank you so much, Jackie. So this year we have a really ambitious agenda. We are going to continue a lot of the work that Lucy and Jackie just talked about this year. We will continue working with ASAM on the 4th edition. As Jackie mentioned, that should be coming out in the fall. So we're really excited to hear about that. So we have some work that we'll have to do to educate the facilities about the change in the guidelines there. We're also going to continue to develop and expand our provider-focused resources. So last year, our resources really focused exclusively on getting folks with bleeding disorders into substance use disorder treatment facilities. But we know that there are just as many, if not more, challenges with getting into inpatient mental health facilities. So we are expanding the provider-focused resources, the provider toolkit, to include tips and tricks and suggestions, recommendations for how to facilitate access to those mental health facilities. We are also beginning some new work at both the state and federal level that really focuses on addressing this issue of discrimination in our community, both at the federal level and at the state level. And so at the federal level, we have already had a conversation with the Substance Abuse and Mental Health Services Administration, SAMHSA, and they were very interested in the work we are doing and expressed a willingness to work with us to really ensure that that people with comorbidities, people with bleeding disorders and other chronic medical conditions who also have substance use disorders or mental health conditions get the access to the treatment they need, that this really is an equity issue. And they saw it that way, which was great. We are also reaching out to the Office of Civil Rights at Health and Human Services. That's another federal agency. And we are hoping to work with them to clarify the legal mandate, that it is a legal requirement that these facilities accept patients with chronic conditions. They can't decide that people with bleeding disorders are simply too complex and they don't want to treat them, that's just not okay. So we're going to continue to do that work at the federal level. We are also beginning work at the state level. So we have selected 5 different states to really look at how the state regulations affect the facilities, both the mental health and substance use disorder treatment facilities in the states. Well, much of the regulation of these facilities is done at the state level, and the states operate pretty differently. Some of the states require use of the American Society for Addiction Medicine, the ASM's guidelines. Other states do not. So it's really important for us to kind of understand on a state-by-state level how we can improve access. So we've selected 5 states, and the reason we picked these 5 states is because we had people in our coalition who were excited about doing some state work. But we have tried to get a group of states that do have some geographic diversity. So California, Connecticut, Massachusetts, North Carolina, and New York. So we'll be working in those states, both at the state agencies and doing some education with substance use and mental health facilities, and seeing how we can have an impact at the state level. We are also working on developing resources for people with bleeding disorders themselves. So we are very shortly, in the next couple of weeks, coming out with a toolkit for chapters. So chapters will be receiving information about the work that we're doing, that they can share with their communities, so that that people like you, people with bleeding disorders themselves or family members, are aware of this issue and know what to do if they find themselves being denied access to the care they need. We're doing presentations like this to raise awareness, but we are also developing a toolkit specifically for individuals with bleeding disorders. So some materials that you can have, that you can share with a treatment facility or share with your provider to help facilitate the access. But with all the work that we are doing, we really need help. So we are looking to the community to help us do this important work. We have BD Sumac, the Bleeding Disorder Substance Use and Mental Health Access Coalition, operates at the coalition level. We meet monthly, but we also have a number of work groups. We have our community chapters and communications team. Each of these teams also meets monthly and does work on all these various issues within them. So we are looking for community members to join our communities team, providers to help us work on the provider team, and then folks who are interested in either on helping us advocate at the federal level to join us on the federal team, or if you live in one of those 5 states that we mentioned, California, New York, North Carolina, Massachusetts, and Connecticut. If you live in one of those 5 states, we would love your help on the state team. So we are really excited to hear from you about whether you have had experiences being denied access to care and what happened there, or if you have questions about the work that we're doing, or suggestions for us. We would love to hear from you. So thank you again for joining us today, and to NHF for the opportunity to present. We really appreciate it.
That was wonderful. Thank you very much for your presentation. Before we hop into the Q&A, we have just one quick announcement. Nominations for the Awards of Excellence are still open through May 5th. You just head over to hemophilia.org/BDC. You go to the program tab and click on Awards of Excellence. Then from that page, you can click on the button for the nomination form. It's just a reminder, self-nominations are not allowed at this time, but you can nominate somebody that you know. All right. Okay, so if you have any additional questions, make sure you throw them into the Q&A or just comment on whatever platform you're streaming on. But our first question for you today is, has anyone used the toolkit thus far, and how did it work?
Jackie, do you want to take that?
I was going to say, yeah, I guess because I just recently used it last week for one of my patients. So, you know, we had a patient who was in the emergency room for over 48 hours waiting for an inpatient behavioral health bed. I'm in the state of Connecticut, and unfortunately, as many people probably know, you know, we are in a national crisis. We are in a behavioral health crisis and an opioid crisis here in the United States. So finding an inpatient bed is extremely difficult at baseline. And, you know, we raise this point because, you know, patients with bleeding disorders, we just want equitable access. We're not asking for, them to jump the line, right? We're just asking, for an equal playing field for everyone. So unfortunately, my patient was denied a facility placement after the facility learned that they had a bleeding disorder. Specifically, they were denied because of the bleeding disorder, and they heard that verbally. I didn't find out about the case until the family contacted me saying, what do we do? How do we communicate to this treatment facility that they have a stable condition? It was a patient who wasn't on any medications. Again, for patient privacy, I'm not going to talk about the diagnosis here or any identifiable information, but they weren't on any medications. They weren't infusing. So it was really just based on the fact that they had a bleeding disorder. And I, let Kate and Marla know. I referred to the toolkit, and we went step by step with the toolkit, and we were able to have our HTC medical director talk with the facility medical director. Once they were able to have that conversation, the facility medical director felt more comfortable having the patient and come into their facility. As our medical director kept saying, was the patient has a stable medical condition. Any patient who slams their head or falls should get care in an emergency room. It shouldn't just be somebody with a bleeding disorder. So we really wanted to stress that, just because they have this diagnosis, just because you have this diagnosis doesn't mean you need to be singled out. You should get appropriate care if your medical condition is stable. If your medical condition is not stable, that's a different story. But this patient's medical condition was extremely stable, had no issues with their bleeding disorder. So again, I went to the toolkit. I don't know if we're giving access to the toolkit. It's on the New England Hemophilia Association website. We can always plug it into the chat as well. So again, there's like a step-by-step guide, and I followed it, and I was successful, and the patient was admitted immediately the next day. So it worked.
I just want to add also that I believe it was mentioned, but honestly, my dog was crying, so it was hard for me to hear. But is that this is a living document. We're constantly making iterations or changes to this document. We're making it not only stakeholder specific, meaning community members, providers, emergency departments, whomever the audience may be, but there are things which are going to work. We're just trying to figure them out. There are things that are going to work better in certain states and in certain areas that, we're going to need, feedback on in terms of how well or how not well in some cases that this is working. We've learned a lot over the last year, and I think it's, it's always going to be a work in progress, if you will.
Fantastic. Do you have anything else to add before we move on to our next question? No? Okay, great. So this is a great question, and it's very timely because March is not only Bleeding Disorders Awareness Month, but it is National Social Worker Month. But what is the role of the HTC social worker in this process?
I can respond to that because I think it really depends on the situation. I've had patients that I find out that they need acute mental health treatment when they're already at the mental health facility. And then, nobody thought to look at how are they going to get infused while they're inpatient. So we've often had to coordinate with them, trying to figure out where the patient could potentially go if they could not stay at that facility, if there was no way that they could get factor in identifying places where they were going to be able to get appropriate treatment. And the other piece of this is we're basically the ones that are often in the front line making these calls, even if it's not the HTC social worker, it's the social worker in the emergency room that the patient came in for in crisis. And they're the ones that are providing the documentation necessary to the facilities to try to get the patient accepted. So it's important to try on as the social worker in the HTC to make sure that you have good communication with the social workers throughout your medical center, to make sure that they're aware that there are potential issues that might come up with patients with bleeding disorders, and that the HTC is a resource to help when you're dealing with a denial of a patient going to any facility. You know, I find myself, I'm often the one doing the outreach, seeing that, oh, the patient's going to need to go to facility ABC, and I know it's going to be an issue. So, you know, we try to be proactive and to let them know, this is what we have dealt with in the past, and here are some suggestions that we can make. But that the patient, one, has a right to get the behavioral health treatment that they need, and two, that there has to be a way for them to continue their treatment so they can safely participate in the program that they're going to be entering. I don't know, Jackie, you have other things, anything else to add?
I think you said that really well. One thing I would say is, for any of the patients on the call, call your HTC. You know, make sure that they are aware, because you know, we can intervene, you know, in the community level. You know, we are trained clinicians. A lot of the HTC social workers are trained clinicians. So we can work on different avenues, and work with you on, you know, figuring out, you know, maybe working with a psychiatrist or going to an IOP, a PHP program. So we don't need that residential level of care, but we're here to help support you. So I just want to encourage you to reach out to us, because that's what our job is. And thank you for the social work shout out, social work month shout out.
Yeah, absolutely. Okay, so what if I'm not at an HTC and I don't have a social worker? How do I get help?
That's a really great question. So we are aware not everybody has connections to HTCs. You know, I am very lucky. I'm in Connecticut. We have 3 HTCs in the state, but we know some people are in rural areas, right? And their local HTC is maybe 5 hours away, and their care is managed by their primary care doctor or another hematologist. Work with those providers. You know, work with your primary care doctor. They, you know, have a lot of information, and they can help support you, whether with medication management. You know, there is medications for substance use disorders. They might be able to refer you to a local psychiatrist or therapist. I would also say that if you are in crisis, if you are actively withdrawing from substances, please go to an emergency room or a detoxification program. That's really imperative, because that can be life-threatening. Do not stop your substance on your own. Talk to a medical provider about it. And if you do go into, let's say, you know, your local emergency room or hospital, and you're admitted in the hospital, that's why we created the toolkits. Provide the toolkits to those providers. You know, let them know these are the steps that work or have worked, right? As Marla said, it's not guaranteed, right? You know, it's still a work in progress, but definitely, you know, give those resources to whoever the referring provider is. Your primary care doctor is an important part of your care, even if they're not treating you for your bleeding disorder. I don't know if you have anything else, Lucy.
Yeah, and I would say too, you know, and when in doubt, I always say reach out to the chapter as well, because they can often connect you with the experts in your state that can advise your providers what to do. And maybe if they don't know how to access the toolkit, you know, I'd be more than, I'm always happy to do a consult and give people the resources that I'm familiar with if asked.
And let me just,
Sorry, go ahead, Marla.
oh, okay. So let me just say, our social workers in this community are the best. You guys hold a very special place in my heart. So shout out to all the social workers. And they are your go-to resource, right? They are the ones that can help you not only navigate before, but navigate after and during, right? They just need to be told. And quite often, you know, whether or not you go to an HTC or not, is that the more people we can get to recognize the signs and, you know, that this is an issue, the better off we are as a community to circumvent these problems and address them soon, or rather than later.
And as a community member, I don't think I said this at the beginning, but I'm the mom of a 6-year-old with severe hemophilia A. And, we have learned how to advocate for ourselves. We have to advocate in so many circumstances. We know more than the medical professionals who are treating us. And so more about the condition that we have than the ER doctor who we're seeing. And so a lot of times it is up to us to share information that we have with those medical professionals. And so this case is no different. We really need to be the ones to let folks know that the reason that we're getting a denial might be because of our bleeding disorder. And here's some information that I've gotten from this national coalition that can potentially help facilitate my access. So sometimes having those conversations with your providers and advocating for yourself and your family is really important.
Great, thank you so much. So we're running down to our last couple minutes. So I have 2 more remaining questions for you, but the first one is, if I'm stuck in the emergency department waiting for a bed, what do I do?
I'll just briefly say, like I said, unfortunately, we are in a crisis right now. So you might be waiting just because there's not any beds available. Or if you're being told that you're denied because of your bleeding disorder to any facilities, reach out to your HTC. Like we said, if you are denied, call your HTC, call your social worker. If you don't have a social worker, call your nurse, call somebody at your HTC, let them know what the situation is. Depending on the circumstances, like Kate said, we have state programs. I know it's just 5 states, but we can work on trying to find out who the state regulators are. So let your providers know, and they can always reach out to BD Sumac. Your provider can reach out to BD Sumac. There are also other levels of care, PHP, IOP, outpatient. So that might be another option for you.
And Jackie, just because not all of us community members know what those are, can you help translate the alphabet soup?
Yes. So PHP, I apologize. It's so ingrained in me, is partial hospital program. So it's basically where you live at home, but you go into a program. It's intensive. You go 4 to 5 days per week, and you're there for about 6 hours. So you're getting the same care you would receive in a residential program, but you're just living at home. And IOP is an intensive outpatient program, and it's a step down from PHP. It's about 3 days a week for about 4 hours per day. But again, you're still getting that residential care. You're just living at home, getting the care. That's really what the difference is.
Great, thank you. Oh, Lucy, go ahead. I see you unmuted.
Oh, yeah. And I was just going to say, when in doubt, always, if nothing else, contact your primary care provider, contact other people that you know of that could potentially help in this situation. Sometimes having a physician that's familiar with you will help you be able to access this care. And like Jackie said, it's not just in Connecticut, it's in every state. Trying to get beds for this type of treatment right now, it can take time. Unfortunately, it can take hours. Emergency room wait times are up all over the country, even for issues like just, routine healthcare issues and beds. So it can take a while sometimes to wait for a bed, and just, it's important to focus on why you're there and not to just give up or feel rejected, but just to keep on trying and knowing that, just if you keep on asking, you will get help one way or another.
And the other thing I would say is share your story with us. So if you have experienced a denial, please let us know. Especially if you experienced a denial and you got in, we would love to know that, especially if you've used the toolkit. We want to know what's working. or if you've experienced a denial and nothing has worked. We need to know that as well. The only way that we are going to address this issue of discrimination is if we can demonstrate that it's a problem. And patient stories can help make change. It really matters to our legislators and to the policymakers to hear from people who live in their states, who live in their communities, who are struggling to get the treatment and care that they need. So, so please help us address this issue at the national level by sharing your story. And if you're willing to lend your voice, lend your time, we really are beginning to make change, which is incredibly exciting, but we need more resources. We need your help to continue the work of this coalition. So, so please, I know, well, we've already shared our contact information in the slides. It will be coming out in follow-up to this webinar as well, but we would love to hear from you. So thank you.
Fantastic. Thank you. And we've got 4 minutes, so I will throw the last question out. But how long is too long to wait in the emergency department?
If you ask me personally as a human being, 5 minutes is too long. But professional, like, I mean, it's hard to say, right? And I'm going to defer to my providers on this call. So
it's really not a one-size-fits-all question. Sometimes if you're seeking behavioral health care, you could be on a psych hold. So we kind of can't tell you how long is too long because it really depends on what you're seeking care for. So I would defer to the emergency room providers. They have physicians, they have social workers there, communicate with them. If they feel like it's a safe discharge plan to discharge into the community and go to one of those other levels of care, that's great. If it's unsafe, if they feel like it's an unsafe discharge, they actually might admit you into the hospital. That could definitely happen depending if you're withdrawing and you need medications to help you withdraw. So it's not really a one size fits all. But again, communication is key. As Kate said, you are your best advocate. You know your bleeding disorder probably more than the emergency room physician, unfortunately, right? But that's really with any rare chronic health conditions. We're coming off of Rare Disease Day yesterday. You have the power to make change, to advocate for yourself. So definitely do that. And always have your HTC, always contact your HTC because we are your advocates as well.
And I would just add that, if you feel like you're stuck in the emergency room and things are taking too long, it's important to start asking some questions. So ask them, why is it taking so long? Is it that there aren't any beds, or is it because of my bleeding disorder? And if there aren't any beds, then you have to wait, or go with what Jackie was saying with looking at alternatives. But if it is because of your bleeding disorder, again, giving your provider some of these tools and resources to help facilitate your access will be important.
Fantastic. Well, once again, I'd like to thank all of you, Kate, Jacqueline, Marla, and Lucy, for taking the time to join us this afternoon. We appreciate your time and your expertise. I'd like to thank each one of our viewers for joining us as well. Please note that this recorded webinar will be available on Friday, March 3rd at hemophilia.org under the events tab with all of our archived webinars. Also available in the events tab is our upcoming schedule for our weekly Wednesday webinar series. Thank you for joining us this afternoon. Have a wonderful week, and we will see you right back here next week as we continue the series. Have a great day.
Thank you.